Hi there, everyone. I haven't done one of these live sessions for a while, so I was just staring at myself for a couple of seconds. Thank you to so much to everybody who's going to join us live for this chat, and also thank you to everybody who watches it in their own leisure, in their own time, on catch up. I sound like I'm on BBC iPlayer, don't I? Yeah, just thank you so much for joining in. And if you don't know what you're joining into, my name is Karen. I work for the Eve Appeal, the UK's leading gynae cancer research charity. And March is Ovarian Cancer Awareness Month. And throughout the month of March this year, we've been talking about the rarer types of ovarian cancer, which we'll explain more about throughout this session. So ovarian cancer is the second most common of the 5 gynecological cancers. Womb is the most common, ovarian is the second. In the UK, every year, there are around 7,500 cases diagnosed. And the symptoms, which again we'll discuss, are very different compared to the other gynae cancers. And it's the one that seems to be the trickiest to diagnose out of the 5. And under the umbrella of ovarian cancer, there are 5 rarer subtypes of ovarian cancer, which I don't think, unless you've sadly been affected by one, as the general public, you'd really know or hear about, because they are rare. They're kind of difficult to understand sometimes. And yeah, they don't have that much awareness around them. So it was really important to us to shine a light on these rarer types of ovarian cancer throughout this Ovarian Cancer Awareness Month. That is a much shorter intro than I normally do, my usual 7 minutes. So I would like to please welcome our guest for today's show, our first of 2 guests. Please come in. Dr. Will Foulkes, here we are. Now I'm going to get this right. I've practiced this. Okay, this is Dr. Will. Hi, Will.
Hello.
Hello. Okay, Will is a James McGill Professor in the Faculty of Medicine and Health Sciences at McGill University. And I was about to say in Montreal, but when I asked my Alexa yesterday when we were emailing, Alexa, what's the time in Montreal? She said the time in Montreal is... So I'm going to say at McGill University in Montreal. Welcome.
Very, very fancy. Very fancy.
Very fancy. Thank you so much for joining us, Will. Could you tell us a little bit about yourself and why you're the person we're having a chat with today?
Hold on.
Can you hear me?
I've got a problem.
Can you hear me? I can hear Will. Okay.
Sorry, I don't know why.
No, that's fine. Okay, bear with everybody. I'm just checking if Will can hear us and if our tech guys can hear us in the background. Okay, fine. So, okay, I think maybe Will had a connection problem because we've got this like backstage area, and I can hear Lydia, our lovely comms manager, who is my best girl, and Ben from Disruptive, who do all of this for free for us, saying in the chat, yeah, all good. And I'm still live, so I'm just going to carry on. Will, can you hear me?
Yeah, I don't know what happened there. Well, I hope it's not me. I don't know what happened. My microphone seems to be fine. I don't know, but for suddenly I couldn't hear you for a minute.
Well, yeah. I did a terrible job at killing time while we got you back.
Well, let's hope that that doesn't happen again. My microphone seems to be all right, so we'll carry on.
Let's carry on. So, can you just tell us, before we get into talking about the different types, can you just tell us a little bit about yourself and kind of why we're speaking to you today?
Well, I'm a geneticist, so I'm interested in the kind of reasons why people get sick, if you like, but particularly cancer genetics, which would be my area of interest. Actually, I did my PhD. You can probably tell from my accent that I started out in the UK. I did my PhD at the Imperial Cancer Research Fund, as it was then, on ovarian cancer, but on high-grade serous ovarian cancer. We were looking for the BRCA1 gene, essentially. This was before the gene was identified, which tells you roughly how old I am. I spent several years working on ovarian cancer at that time, and then essentially in a roundabout way, I got back involved with ovarian cancer in Montreal, but in this time, I got more interested in the rarer subtypes. So I'm a clinical geneticist, so I see patients who are at risk for ovarian cancer or have ovarian cancer, and offer them genetic testing to try to understand why they developed the cancer and what their risk is, what the risk for their daughters and sisters and mothers might be for the same or related cancers. So that's very much part of my clinical practice. But at the same time, I'm interested in the why part of it. So in the lab, we focus on families. So we collect families where there's been more than one person with the same disorder, because if it's a very rare disorder, then if you think about it, if there's two people with a rare thing in your family, it doesn't take a geneticist to say, that's probably not just chance. You can get hit by lightning, but you don't get hit by lightning twice. So unless there's something really, you're walking around with a metal pole. So
yeah, unless you're being very silly about it all.
Yeah, exactly. So that's really how I got interested. And through reading and spending time thinking about things, we got involved with particularly small cell cancer of the ovary and sex-cold stromal tumors. We've also got a project on germ cell tumors that's ongoing. So we kind of covered the gap, and also a little bit some other rarer types, but mainly those three types, which we can talk about later today.
So you've not done much then? Nothing compared to my drama degree, my BA honours in drama. Nothing much.
It takes all sorts.
It takes all sorts. It really does. It takes a village. Will, so let's kind of get into it and talking about the rarer different types of ovarian cancer. Now, if people don't know, I think we'll have a mixture of an audience, some people with already a vested interest and some people that just want to find out a bit more and are curious.
Right.
Is it fair to say that if we think of the umbrella of ovarian cancer, the next kind of step down, you can divide into two, with epithelial ovarian cancers and non-epithelial ovarian cancers?
You can. That's very fair. So so if I can take it from there for a
Yes,
second.
please do.
Are by far the most common. And within the epithelial, there's essentially high-grade serous cancer of the ovary. That's the one that's linked to BRCA1 and 2, and that's the one that I did my PhD on. So that's a very common. That's sort of 70% of all ovarian cancers will be that type. Okay.
Oh wow, so that's quite the majority, isn't it?
Yeah, by far the most. And then other epithelial cancers would include clear cell carcinoma of the ovary and mucinous carcinoma of the ovary and endometrioid carcinoma. So there's those three groups. And then the non-epithelial group is split into multiple types, but particularly three groups, which would be called sex-cold stromal tumors, germ cell tumors, and the so-called miscellaneous group, which is essentially, we don't know really what these are. They don't really form a group, so we'll call it. So this is the so-called WHO classification of ovarian tumors, which is the one that everybody uses. And within each group, there's sort of 1.2, 0.3. There's a lot of breakdown of each subtype. So there's many different types of sex-cold stromal tumors. It's not just one type. So it's actually quite a complex. Pathologists love this because they like ordering things and sorting out who's got what. But it's not a completely. It's not just a question of just ordering things just for the sake of it, because these tumors are very different. And as we found out from small cell cancer, it's a very different tumor to some of the other types, even though it's in this miscellaneous group.
And before we kind of then dive into the different factors of the different cancers, just because I think I don't know if people watching this will know, what does epithelial and non-epithelial mean? What does the word epithelial mean?
Well, epithelium is essentially the sort of the top layer. If you like, your skin is epithelium.
So that's epithelium.
Yeah, your colon is. If you think about it, your colon is there's a tube that goes from your mouth to your rear end, which is kind of outside of your body. If you think about it, it's not inside, right? So the epithelium is lining everything. So the inside of your mouth, your throat, your gut, that's all epithelium. Okay, so the ovary has this one cell layer on the top called the epithelium. But because you asked me that question, I guess it provoked a thought in my mind that it's actually a bit of a misnomer, because high-grade serous ovarian cancer probably doesn't actually mainly arise in the ovary at all. it mainly arises in the fallopian tube, which is another epithelial structure right next door. So if you imagine the fallopian tube, it's sort of like this, a little sort of the fingers at the end of the foot. Here's the ovary. The fallopian tube is right next to it. So every menstruation, there's going at every ovulation, there's going to be an egg escaping from the ovary, going into the fallopian tube here, and these little fingers kind of guide the process. And we think the cancers arise actually from this part, but this is all epithelium. So the surface of the ovary is just that one layer of epithelial cells. So in a sense, it makes sense that a tumor, if it's epithelial, would come from a region where there's a lot of epithelium, which is the fingers of the fallopian tube, and not this one layer, because the ovary really only has three things in it, apart from a few nerves. It just has the epithelium, it has the stroma, and it has the eggs. I mean, that's it. It's a pretty simple structure. It's not like the brain or like the heart or something. It's fairly simple, actually. It really got one important function, which is to make produce the next generation. So it's pretty critical, but it's actually quite simple. So the cancers that must originate from these types of cells. So the epithelium is where the high-grade serous cancer comes from, but most people think, and the conventional theory now is that the vast majority of these tumors actually arise from the fallopian tube. So preventing high-grade serous cancer of the ovary requires preventing fallopian tube cancer, essentially.
So that's, do you know what, I've never in all my 21 years I've never I wish, yeah, we both wish. I've never heard because obviously working through the pill, I knew that the thought is that they tend to actually originate in the fallopian tube rather than the ovary, but again, I don't think that's common knowledge. So that was so beautifully explained, and I've never heard it explained that kind of well and visually, in terms of thinking, well, of course, if there's more epithelium here in the bits guiding the ovary down the tube, of course.
The extraordinary thing is when you look at the fallopian tube, it's like the coast of Japan. I mean, it's incredibly crinkly. It's not like a tube. The inside,
it's not like a
no. It's not like a drain pipe. It's
a tunnel.
It's very convoluted. So the actual surface area is enormous.
Yeah, of course.
It's enormous.
Yeah.
I mean, the surface of many organs, like your lung, is the size of a football field if you stretch it out. These organs are very convoluted. So the fallopian tube has a lot of cells there that could contribute, and that's probably that explains a bit why it doesn't really mainly come from the ovary, because the ovary itself, if you think about it, is a tiny organ with a huge risk. Why would it be so? It's the size of an almond, and is the fifth commonest cancer in women. I mean, this doesn't make any sense.
It doesn't make sense, no.
It makes sense only when you understand the facts a bit better.
Yeah, and of course, like if there's more epithelium on these bits rather than the one little cover of the ovary, there's more chance for something to go wrong the more of something there is.
Yeah, that's right. And if you don't have the fallopian tube, then probably you don't have the risk.
And so with regards to epithelial ovarian cancers and the rarer types, can you talk us through the rarer types of first of all epithelial?
Clear cell. So clear cell mucinous will focus on. Okay, so clear cell is a very different type of thing. Clear cell is really most strongly related to endometriosis. In a beautiful paper in the New England Journal of Medicine some years ago, two groups showed that ARID1A mutations, which is a gene, are common both in endometriosis and in clear cell cancer of the ovary. So it's it's very much related to endometriosis. That's probably the most important risk factor we know of. Okay.
So does that mean that if you have endometriosis, you're likely to get clear cell, or just that a lot of clear cell patients also have endometriosis?
I think there's an etiological relationship, but it's not. I don't want people to think, oh my, because there's a piece in the BBC you probably saw yesterday about endometriosis. 10% of women suffer from
exactly. That's what I'm thinking. Yeah.
So obviously 10% of people don't get clear cell cancer of the ovary. So it's what you call a relative risk. So the risk, if you have 100 women with endometriosis and 100 women without endometriosis, the 100 women with endometriosis, one of them will let's say 1 or 2 will get clear cell cancer of the ovary, and none of the other groups. So it's more common, but still 98 won't get it.
Of course.
So it's not like you're destined to get it, but it does increase the risk. So that's one thing. Then mucinous ovarian cancer is very different. It's actually a mysterious condition in many ways. Nobody quite knows where they come from. What kind of, there's some question they may be some kind of teratoma. No one's sure quite where they come from. They're very different.
What does teratoma mean, Will? Just if people don't know.
Teratoma is a Greek word meaning monster. So a teratoma is a tumor, and that's related to germ cell tumor. So a germ cell tumor, so we're skipping ahead, but a germ cell tumor is a type of attempt to form all the layers. The body has 3 layers. It's an attempt to form a body, but without the guy's contribution. So it's just the ovary cell tries to make sort of a human, so you get bits of hair and bits of teeth and weird.
Okay, so these are the cysts that people might have where they find with hair and teeth in when they're 45 or something.
Those are the benign ones. So there's some suggestion that a mucinous tumor maybe is like with that program gone a bit wrong, but they're very different. They tend to be very large. They tend to have a much better outcome, except when they metastasize. When they metastasize, they're bad news, actually. They're as bad as a high-grade serous if they metastasize. But fortunately, most cases don't. They're not very common. It's very important to have a good pathologist, going back to pathology, because a lot of mucinous ovarian cancer are actually colon cancers that metastasized or from another organ in the GI tract. They metastasized to the ovary. And the ovaries are very interesting. It's sort of like a shapeshifter that when a cell arrives in the ovary, it kind of changes it. So it doesn't look like it looks like an ovarian cell, even though it came from somewhere else.
So it can kind of disguise it in a way.
It disguises it, exactly.
Yeah.
There's a thing called Krukenberg tumors where you get stomach cancer that goes to the ovaries. It's a sort of a well-known phenomenon, been known for a long time. So the ovary is a preferred site for metastases from adenocarcinomas. So sometimes a mucinous tumor may be incorrectly diagnosed. It's very important to make sure that the pathologist has really looked at it carefully. We had a case recently actually that was diagnosed as a mucinous ovarian cancer, and it turned out to be a yolk sac tumor. So when we got it reviewed, there's a pathologist in here, Lily Fu, who did a great job and worked with Glenn McGluggage, who's in Belfast, who you probably well know, and Eva Peel, who's really one of the leading gynecopathologists in the world. And together the two of them worked out this was actually a yolk sac tumor, which is a germ cell tumor. So again, the mucinous germ cell connection came through there, but it made a big difference because it's a very different diagnosis. So that they can be tricky, but overall the prognosis is usually good. They tend to present as large cysts. And because of that, they tend to have a better outcome because you present with a big, you've got this pressure in your tummy. Whereas with high-grade serous cancer, before by the time you've got it, it's already spread. So it's a much more difficult thing to treat.
It feels a bit weird to say this because I wouldn't normally say this in kind of cancer chat, but it's kind of like it's kind of good that the tumors start off turn up quite big, isn't it? Because they make the symptoms early. Yeah.
When I was doing my PhD, I actually go to the operating room to collect all these tumors. I was on my bicycle biking around London collecting these samples in liquid nitrogen for my own project. I mean, it was do it yourself.
Yeah, so DIY job. Yeah.
And I remember going to the operating theatre, seeing these enormous tumors coming out, and they would be giving me a piece of it for my research. But these were enormous, sometimes like a football, or a melon. I mean, huge. So or even bigger. So that's right. The fact they grow very slowly and tend to grow on the inside of a cyst that is not ruptured. So it's like the inside of a football or a melon. The surface, as long as the surface is all nice and smooth, and the surgeon gets it all out in one go, then usually the outcome is very good. They're not very genetic, interestingly. They don't turn up in families with cancer very much, unlike high-grade serous cancer of the ovary, which is highly genetic, probably one of the most genetic disorders in adults that we see.
So mucinous isn't associated with the BRCA.
No.
And
clear cell fits with
cell, yeah.
That goes with Lynch syndrome. So Lynch syndrome is due to inherited mutations in genes that tend to cause colon cancer and endometrial cancer, but rarely they can cause clear cell cancer of the ovary. BRCA1/2 sometimes causes clear cell cancer. I've seen a couple of patients with clear cell cancer of the ovary, and probably, now we would say that all patients with ovarian carcinoma or cancer of any type should have some form of genetic sequencing of their blood to find out if they're at risk, because you just can't know. I mean, as I say, clear cell are usually Lynch syndrome, but I've seen a couple of cases caused by the BRCA genes, and they've been validated to be definitely clear cell, not misdiagnosed other tumors. So I think, you have to be, cautious, and, it's like with anything, there are always exceptions, but generally clear cell is more of a Lynch syndrome problem, more than a BRCA1/2 problem. And mucinous, as I say, we've even had cases where mucinous cancers occurred in people in families where there was a known mutation in a breast or ovarian cancer gene, but the person didn't have the mutation. So it was, so exactly. So mucinous is a mystery. I think it relates to smoking a bit, but there's really nothing much else there.
And with regards to clear cell and mucinous, which is more common, and do they affect, typically, again, general sweep, but do they typically affect the same sort of age groups, or do you see one in younger people?
I think clear cell's a bit younger, actually. Mucinous, I'm not quite sure of the age of mucinous. I think it's generally older women, to be honest, that I've seen. But I don't quote me on that one.
No, okay, no, that's fine.
I'm not really sure.
You've done the.
Have been older women,
Yeah. Don't you can absolutely say no comment to something, Will. You're doing the best explanation of different types of ovarian cancer I've ever heard, so I am loving this. Loving it. Moving on. Germ cell. So clear cell and mucinous are a type of epithelial, which we've explained what the epithelium is. Now, moving on to non-epithelial, germ cell. Can you tell us what that is?
So germ cells are, in some respects, are probably one of the commonest types of ovarian tumors, but that's when they're benign. So they're dermoid cysts. They're the ones with the hair and the teeth. Okay. And they look very mysterious. You open these things up, and you see hair and teeth, and it's bizarre.
And so people say, "Oh, I was carrying my twin," don't they? You hear that a lot. Yeah,
exactly. Yeah. So they are teratomas. They're an attempt to form, the three layers of it. So you get brain tissue in them, and there are these. You may have heard about this extraordinary disorder when people get go into fugue states because of a germ cell tumor that has got brain in it, and you get antibodies against the brain tissue, then attacks your own brain. Extraordinary. There was a book written about it recently, and one of my patients actually had it. So it's an extraordinary condition, but so they can do very strange things. But usually, dermoid cysts are relatively innocuous. They get removed because they get to be large, but they don't spread. They're benign tumors. There are rarely malignant germ cell tumors, okay, and the yolk sac tumors and things like that. They are much less common and don't have such a good outcome. Tend to affect younger people, but the outcome is better than for the high grade serous cancers, but they're not benign. I mean, they do metastasize, so they need chemotherapy and so on.
Quick question: if can a benign germ cell tumor, can it turn cancerous, or is it either it is or it isn't? Or if I have one, am I at risk of it developing into a malignancy?
The only way it can is within a teratoma, because it can do anything. Some of the cells within it could become cancer cells. It isn't that one of the, for example, you can get there's a type of kidney tumor called a Wilms tumor, right? This is the commonest pediatric kidney tumor, okay? And sometimes you can, when you look at the teratoma and you look inside it, you see Wilms tumor. So the child essentially has a Wilms tumor arising in the ovary. It's one of those sort of miscellaneous cancers, actually. It's extremely rare, but because it has this sort of differentiation that went down the pathway of kidney and then maybe picked up a mutation along the way, it ended up being an actual tumor as opposed to just a piece of kidney. Because, kidney itself, obviously Wilms tumor comes from the kidney, so you have to have kidney cells there in the first place. So the first step is to have it, because there could be anything in a teratoma. It could be neural tissue, could be hearts, could be anything, because it's
anything,
anything. So that's why they're so bizarre and kind of interesting to pathologists, but they're very bizarre things. But if there's a tumor within it, yes, it could be. But then you'd be treating the person for the tumor that was produced in the teratoma rather than the teratoma itself.
Yes, I understand. So that and germ cell, you were saying, typically affects younger people compared to some of the others.
But malignant and benign. But interestingly, you see, it's a strange story. Is that male benign teratomas are incredibly rare, whereas testicular teratomas, we all have heard about those. You know, famous people have had the famous jockey, my era Bob Champion. You know, who won the Grand National.
You're showing your age there, Will. I've drawn a blank. I haven't got a clue what you're talking about.
Aldeniti was the name of the horse. I remember the horse, and he won the Grand National after beating testicular cancer, and that's a malignant tumor. So for the males get malignant tumors of the testicle, and benign ones are very rare, and women it's the other way around, and nobody knows why. So the benign ones are much more common. The malignant ones are much rarer.
And before we move on to sex cord stromal cancers, because we mentioned germ cell, just a quick thank you to the lovely Sarah, who is a trustee for the Robin Cancer Trust, a great charity that provide information and awareness on germ cell cancers. Just to say thank you to their trustee Sarah, who shared her story of an ovarian germ cell with us this Ovarian Cancer Awareness Month as well. Yes, just a quick shout out and thank you to Robin Cancer Trust and to Sarah. But moving on, okay, so sex cord stromal, is it stromal, sex cord, or sex cord stromal? What is it?
The official title is sex cord and then hyphen stromal tumors.
Okay.
Sex cord,
what is
hyphen
it?
Stromal. Because sex cords are the cords, little cords within the tumor which produce hormones, which could be either male or female. So you can either get androgen male type symptoms, like you can get hair on your face and your voice can deepen and things like that, or you can get female hormones produced. So they are hormonal, and
they're non-epithelial.
Correct, and there's multiple different types. And the major gene there for the type called Sertoli-Leydig cell tumors is Dijon Syndrome, which is an inherited mutation in the gene DISA. So they're also rather uncommon, but affect all ages. Usually a bit older, actually. Usually not very small children. Usually adolescents and up until the 60s and 70s, and they usually again are quite okay to treat, but again if they're later stage they can be difficult to treat, and if they there's a big study recently from France, a huge study looking at all the cases that metastasized, and then the outcome isn't so good again. So if you get them at the earlier stages, they do very well, and they tend to be earlier stages. But if they spread, the outcomes aren't so good. So that we still need to understand more about, why do certain cases, spread more than others.
And you said that they tend to, compared to some of the others, get diagnosed early, which is obviously a good thing. Is that because, like with the mucinous, they are massive and then push on things and swell a tummy up, or how come?
It's more the symptoms, because because when we get other symptoms that aren't right, they feel if they get, for example, a case I know of that I was involved with was a woman who was breastfeeding, and suddenly she wasn't able to breastfeed anymore and didn't know why. Went to the doctor and he started asking questions, and it turned out her voice had got deeper, and she had some hair developing on her face, and she thought it was a bit weird, and they realized the hormones were out of whack. And then one of the obvious places to look if hormones go out of whack is in organs that produce hormones, one of them being the ovary. So she had an ultrasound scan and made the diagnosis. So she had Sertoli-Leydig cell tumor producing androgens.
And we talk a lot about the kind of common symptoms of ovarian cancer, like the bloating, the bowel changes, the urine problems, the pain, etc. And less common are things like when people say that their periods have stopped. Like that's not typically, compared to your bloating, an alarm bell for ovarian cancer, but would period stopping kind of correlate, if with any of them, with the sex cord stromal, because it's hormone dependent? And
I think the point is they're just so rare that it would be a pretty smart doc to pick up. Oh, your periods are stopped. Okay, you've got to But it's certainly a constellation, isn't it? It's when things persist. And when they are consistent, and when it's more than one thing, you put if you've had a symptom for a couple of days, okay. If you've had it for weeks, this is kind of when you begin to question. And certainly unusual symptoms like developing a deeper voice. I mean, you can't explain that away.
No, of course, yeah.
Somebody would say, hey, what's happened? What's happened to your voice? Someone else might notice it. A partner might notice it, or you may, there's certainly these symptoms do happen, and we certainly pick them up that way.
And it's about, isn't it, going and speaking to your doctor when you notice something, even if it's not what you typically associate with whatever we're talking about, i.e. the bloating, etc.
Persistence, I think, is important, because things come and go. I mean, every day we can feel a bit off and go on for a couple of days. But if something goes on for I would say more than 2 weeks than less than a year, then I would worry about it.
And the last one, is it fair to say the rarest? Small cell.
Probably small cell cancer of the ovary. Yeah, rarest type probably. We're running out of time, I think, but I would like to, at some point.
Of course, no, it's okay. Go for it. We can go a little bit over, but Lydia can't tell me off. Lydia, if you're backstage, don't shout at me.
Okay, so small cell cancer of the ovary, it's a bit like the Holy Roman Empire. Not as Voltaire famously said, not holy, not Roman, not an empire. So they're not really small cells. They can be large cells. It's not a carcinoma. It's not an epithelial tumor. And the hypercalcemia doesn't always affects about 2/3 of women, but some, there's high calcium levels. Some women don't, many women don't have it. So it's not a great name, but we're kind of stuck with it now. So I think that's the name we're going to use. Small cell cancer ovary hypercalcemic type, SCOOT or SCOT, or you can choose your own.
However you want to say it.
Yeah, abbreviation. I call it SCOOT. Abbreviation.
Yeah.
Easier to say, perhaps. So these tumors are very, very unusual in that they do seem to arise in the ovary. We don't know what the cell of origin is. It could be a germ cell, but we don't really know. And they grow very quickly and are very, very difficult to diagnose ahead of time because they grow so fast. And I mean, the reason why they're very important is because although they're extremely rare, the average age of onset is less than 25 years. So it's
really young.
The youngest case is like months, and the oldest is about, I think the oldest one we've seen is about, 58, 59, 60. So it seems to stop, which kind of fits slightly with the idea of it being a germ cell, because, the germ cells probably, fade with time in women. Obviously, the reproductive period is past. So that would fit with that, but we don't really know. Certainly the only cases I've seen, we were involved in a case from Australia when the woman, mother died of it, and she was very worried, and she told me she was 65. I thought, it probably, and it turned out not to be. It turned out to be a different type of small cell cancer of the ovary. There's two types. There's the pulmonary type and the hypercalcemic type. So the hypercalcemic type is the one that we're interested in. And it turns out that quite a lot of them are actually inherited. In other words, the mutation is present in one of the parents as well as in the person with the tumor. Or it occurred just in the woman, but she has it in all her cells, all the cells of her body, not just in the ovary. So it can either occur just in the ovary, or it could be everywhere. So in other words, inherited or acquired. And if it's inherited, there's obviously risk to other people, and that creates a dilemma as to how you manage, if you have a mutation in this gene, which is called SMARCA4, what do you do about that? If you have it, do you offer people preventive oophorectomies to remove their ovaries when they're young? I mean, it's a real, we really struggle with these cases. But the major push is to develop new therapies. So if I can share my screen for a sec.
Yes, please do. Right. And whilst you're sharing, I just have a question to sort of take us through the transition. You're saying how it kind of starts in the actual ovary. Is that, this may be a silly question, but because it's kind of going on inside the ovary, does that, because we have two ovaries, mean it's also happening in the other ovary? Or is it kind of just...
It's a very unusual tumor, and it only seems to occur in one ovary in most people. Very different to high-grade serous cancer of the ovary and endometrioid cancer. We do have at least one case of proven bilateral, both sides, in a very unfortunate woman who developed this disease twice, who has an inherited mutation. But usually it just affects one ovary, and again, we don't know why that is. But anyway, so this is a registry we set up with the support of the Eve appeal. Maybe we can go on to the next slide, but I'm not having any success doing that for some reason. Hold on.
While you're trying that, I just yes. So as Will just said, this is supported by the Eve Appeal, and we've got a small. Obviously, we fund lots of different research, but we've got a specific small cell ovarian cancer fund, and it would be very amiss of me to do this session and not thank every single person that's donated every single pound to this fund. It's a classic example of seed funding. What with the money that people have donated to this, they've been able to quadruple the amount of research being done into the world of small cell cancers.
Yeah, we were able to, because the Eve Appeal supported us, really right off the bat after a meeting in London in 2016, we were able to apply to the Department of Defense. Strangely enough, American Department of Defense funds quite a lot of research, and they were very impressed with the fact we'd already got this support. So essentially, I want to thank the Eve Appeal for getting this going. And essentially, it's the idea of trying to understand more about small cell and collecting samples from people. So anybody with a small cell cancer in the past or currently has such a tumor, or a relative had it, or any person with a known genetic variant in the gene that causes the condition, SMARCA4, is welcome to be part of it. Essentially,
so they don't have to currently have the cancer; they can have had it 5 years ago.
No, or even if it was a relative who unfortunately died, we're interested to collect as much information as possible.
Okay.
So Melissa Takjin is the person running the registry, and we'll be in contact with you to answer all these questions here, to help you answer these questions. We're trying to build up a information database. It's a rare condition, so these aren't huge numbers, but so far we've been able to consent 39 people. We've got 9 families participating, and we've got blood samples from 17 of the people. We've got the tumors. It's more difficult to collect them because you've got to go back to the hospital, but we have, we're making some progress there. And I thank you all for those of you who've helped us with that. And you can see it's not just Canada and the US. The UK is obviously doing extremely well there. Also support from all around the world. So we're beginning to reach out to other countries. It is really the only registry in the world. It will, I think, be the only registry because it's so rare. There's no point having 2 of these things.
You may as well. If someone else starts one, I'm just going to tell them to find you.
Right.
Yeah.
And for those of you who are interested, we're having a sort of a public forum, a bit like today, but just for small cell cancer, with some speakers who are experts: Amit Oza from Toronto, Joseph Bressy from Cincinnati, Glenn McCluggage, I mentioned him earlier, from Belfast, Sidong Huang, my colleague from McGill, and Basil Tessier-Cloutier, who's a pathologist from Sloan Kettering. Just a sort of a roundtable discussion. So those of you who want to know a bit more, please do log in. We're currently it won't be as fancy as this, but we're trying to organize it ourselves.
Oh, stop. We will when we share all of this on our socials and website, we'll put the contact details, etc.
Great,
in there as well. So yeah, people, don't worry about scribbling this down. If you're watching this, we'll give it to you.
So that's the name of the website. If you just type scoop SMARCA4.ca into your Google, you'll definitely find it. And I do hope that you'll be able to contribute if you're interested, or just have questions. That would be wonderful. And I say that's how you contact us. But we'll put that on the Eve Appeal website. And I do again want to circle back, because really without that initial support from all the people at Eve Appeal, I don't think this would have got off the ground at all. And really, that was a very I was extremely pleased that Eve Appeal had the foresight, because after I'm not based in the UK, and you could say, well, why don't you fund UK people? Well, it was led by a UK group, Mark Tiskovich in Cambridge and other people. But in the end, it just looked like there's a little bit more going on here. And I really appreciate the fact that you didn't respect the borders and said, hey, who's doing the work, and helped us get off the ground. So thank you.
And also, it's our pleasure, and everybody that every penny, every pound that they contributed is, as I hope you can see, is really making a difference with people like Will's work.
Well, if you come on the 21st, Sidong Huang from McGill has really got some very exciting new data on better treatments, which is really the target of the whole thing, is better treatments, because I think early diagnosis is just too hard. And prevention, I don't think, apart from removing the ovaries, which is obviously a non-starter for most women, you don't know they have a risk, is going to be tricky. So I think better treatment's the way forward.
It's the way forward, as opposed to I understand. Yeah. And also, well, I think, yeah, thank you so much for coming to chat to us today, because I think hearing expertise and research, but especially in an area that's lesser known and not really discussed that much, I think obviously every single person with any type of gynae cancer is, you know, has a valid, important experience, but the rarer subtypes really don't get spoken about. You know, we don't hear much about them. So yeah, thank you so much for giving your really particular expertise. I had such a good chat with you. Thank you.
Great, my pleasure.
Thank you so much, Will. Thank you.
Pleasure.